Hispanic and Spanish speaking. More than 70% of the population in the Rio Grande Valley are either overweight or obese. And the following slide is a photo of our clinic. That's the front door. And the next slide is a list of the staff in our office. Besides me, Myrna Marchand is our nutritionist. Beatrice is here with us today. She's going to be helping with the presentation. And Rebecca Castillo is our clerical assistant. We are a patient-centered medical home and an FQHC. And the program services regarding our diabetes, we offer classes. Sometimes our patients are referred directly to the diabetes classes. Sometimes they're referred for an individual appointment, and then we refer them to the classes after we meet with them. Some patients are refer themselves. They hear about our program, or they just show up at the counter in our department. Sometimes the needs of the patient are better met in individual sessions. We try to be flexible. Sometimes we have people with a little bit of mental disability or other issues that they are very uncomfortable in a group setting. So we try to be, again, flexible to our patients' needs. We also have two promotoras who focus exclusively on our migrant patients, and they make home visits and they can offer classes in the home. And a part of our program is our glucose meter program, our glucometer program. We like all of our patients to have access to a meter and to the supplies. We have a contract with a company that provides us free meters, and we buy enough test strips because we buy enough test strips from them. The program originally was designed for patients who had no insurance coverage, but now more have some kind of insurance. However, many times the plan doesn't pay for the meters or the strips, excuse me, or there's a high deductible. We try to be flexible with the patient's needs. On the other hand, the meter is an incentive for getting the patients to the classes because we ask them to attend all 4 classes before we give the meter. Although, as the slide says, there's always room for exceptions in that too. Sometimes if we see their sugars are elevated during the classes, we will give them a meter and have them come back the following week with their blood sugar log. Sometimes the provider or one of us wants to see the patient's blood sugar in 2 to 4 weeks, so we give them a meter and have them come back with their log. We have a wonderful relationship with our pharmacy, which is on site. They have agreed to send us any patients that come in who haven't requested test strips for more than 3 months, even though they've had refills. That usually is an indicator that they haven't been monitoring, but not always. But it does give us the opportunity to catch up with some patients with whom we've lost contact. So usually that patient will come to see us from the pharmacy, and they will agree to return with us in 2 to 4 weeks with their blood sugar log. And we try to present this as an opportunity to see what is going on and how we can help, especially if they haven't been monitoring. And usually if they haven't been monitoring, their sugars are more elevated. We often find out a lot about what other issues the patient may have been dealing with that makes their priorities very different from ours. It can be a time for us to do more listening. Sometimes these encounters do re-engage the patient in self-management. Also, we try to run reports of all of the A1Cs over 9, and we'll find people who have lost contact with us, all who have never been in our department, and they may have been given referrals and appointments but didn't show up, or they never made an appointment even though they were given a referral. So we try to capture those patients as well by running those reports. And the patients who have completed all the classes are then scheduled for an individual follow-up when they bring their log in for review. And we also are experimenting with group follow-ups, and we've had some success with that. The patients sometimes bond with each other during the series of the 4 classes, and they enjoy meeting again together. So the meter, is really a tool for encouraging participation in self-management. Why do we give patients a meter to begin with? It is a tool for reading their own bodies and learning the various effects of specific behaviors on their sugar levels. While reviewing the log with the patient, we can ask questions like, what do you think of these readings? Get their input. What numbers on this page do you prefer? How do you feel with this number or that number? And we try to avoid overemphasis on the elevated readings. If there's one reading, only one reading on the page that's within range, ask what they think happened there. Why was that one good? Or for the high readings, what do you think is happening? Why are they running so high? And it's a good way to engage them and find out what they think and how they're feeling. And we assist the patients in identifying any small change that they might be willing to try, whether it is regarding diet, exercise, or even stress management, and be ready to negotiate those small steps. For example, I might say to a patient, okay, today we've talked about limiting starches, eating more vegetables, needing exercise. Out of all of these things, what do you think would be the easiest thing for you to work on in the next few weeks? And they will usually say something, and then it's, okay, well, let's work on that, and let's see how you're doing when you come back. Sometimes the patient is taking their medication inconsistently, and for many different reasons. We'll talk more about that later. But sometimes it might be their fear of hypoglycemia, or just that common misconception, I'm already taking too many medications and I don't want to take any more, and so I'm going to take less than what the doctor said because I don't want to cause any more problems. So, for example, if they're having fears of hypoglycemia and they're running, 115s and they feel hypoglycemic and they don't want to take their medication, we go over what they can do to manage their hypoglycemia. And I might ask them, would you be willing for 1 week or 2 weeks to take your medication on time or as scheduled, and let's see what happens, and specifically address the hypoglycemia and what they can do to manage that, and so that they can learn that their body will readapt to those more normal levels if they've been running really high and they're having hypoglycemia at 130 or 140. And then if a patient seems to be taking their medication appropriately, they seem to be following their dietary recommendations, but their sugars are still remaining unusually high, then usually stress is a factor. And we need to be aware that sometimes the source of stress is out of the patient's control. We can assist the patient in identifying where the stress comes from, where there is control and where there isn't. And we'll talk more about stress later in the presentation. But those are ways that we like to use that glucose log to help the patient understand what's going on and learn how behavior change can make a difference. And so now we're going to go through the 4 classes, very basically what things we talk about in each class. Class number 1, of course, is just basic diabetes etiology, the function of the organs involved, the symptoms of hyper and hypoglycemia, the role of starch in your blood sugar levels and stress on the pancreas. How do we diagnose diabetes versus prediabetes? We talk about the A1C values and home monitoring, and we discuss cholesterol levels and blood pressure. And a big part of this first class is talking about the difficulty accepting the diagnosis of diabetes, because really to accept that you have diabetes means you have to accept that you need to make changes, lifestyle changes. And that is really difficult. The longer you have some of your habits, the harder it is to change. Each person has their own time for acceptance, and we need to acknowledge that. Some people have had diabetes for 20 years, but they still haven't accepted that they need to make changes. Then there are a lot of emotional reactions that go with diagnosis, such as anger, denial, sadness, sense of loss. And we need to acknowledge those, and I usually ask for people to make comments, and usually someone will make a comment about how they felt when they first found out they had diabetes, and if they still feel that way, and sometimes they'll say, I still haven't accepted that I have to change, but I'm here today, so maybe I'm ready. Something I like to repeat at the beginning of every class, throughout every class, is, yes, change is difficult, but is it impossible? And it's not. So then we move on to class number 2, and this is about meal planning and dietary guidelines, and I'm going to turn it over to Bea now. She's going to talk about this.
Hi, everyone. How Pam was saying, class number 2, we usually, this is probably our longest class. We like to focus a lot on the meal planning and portion control. We have to be aware that when we're talking to our patients, that what can work with them. We know we can put a particular time for them to eat, a certain time, the portions that they need to eat, but sometimes we have to be aware of their work schedule, the long hours, graveyard shifts, etc., things that we might not know that, they don't have control over that. So we are very conscious about when we're teaching our patients how to eat properly. We go over the food pyramid, of course, the balanced plate, and the new incorporation of physical activity. A lot of these patients work very physical jobs where they're on their feet the whole day, and we're educating them that they still need to do exercise aside from their work activities that they do. We also like to use hands-on activity, which we found out has been very successful. We had food models there with us during the class, and aside from helping them understand each food group and which portion they need to be eating, they socialize with the group. So these patients have had diabetes 25 years. Some of them have been for a month, some of them a week that we've had them. So it helps them identify themselves with another individual with the diagnoses, or even a family member that's had them. So we usually ask for 3 volunteers with the food models to create a breakfast, a lunch, and a dinner. And before us even helping them, the patients, you would see the patients themselves, you're forgetting a starch, or you're forgetting your vegetables on that meal. So they get to interact with one of each other, and actually it's a teach back that they're actually learning something during that group activity. We also like to focus on the reading the labels, something very important that we ask them, what's the first thing you look at when you look at a label? Like, well, I don't even read them. Or some of them might say, oh, the sugar. But as you see in the presentation that we have, the chips there, we tell them, well, it's 140 calories, but in 14 chips. So I was like, oh, I've never paid attention to that. So that's one thing we've noticed, that, teaching them how to read the labels. And, of course, we do go over the guidelines of what's acceptable, the quantity of sugar, sodium, carbs, and fats, and, of course, the serving size of each of the meals that they're going to be consuming. And the next slide, we also have to become aware that some of these patients are on food stamps, or they're having some kind of economic challenge. So we recommend seasonal fruits or vegetables. They can find these at a local flea market, or any, when towards the end of the month they're running out of the food stamps. So what can they do? We negotiate, try to do frozen vegetables and fruits versus canned. Although some of these patients, if there's no other option, we tell them go ahead and have canned, but maybe offering them low sodium, or no added sugar to that. We also recommend inexpensive ones like nopales, carrots, cucumber, cabbage, whatever. Us as educators, I think that's a little bit more of our homework when we go to the grocery store. We know what kind of vegetables or fruits are a little bit less expensive and more affordable for the patients out there. So we can give those recommendations of, they can incorporate these veggies and these fruits into their daily diet, and just add them to them. Also, we like to like to use portion control. You know, we all have those measuring cups, but you know, a lot of these patients go out there to the restaurants. I mean, I go to the restaurants and I don't take my measuring cups with me there. And our migrant workers, these are our migrant workers as well. They're not going to take this. You know, they are working long hours. So we do use, I like to teach them that, you know, your protein is about the deck of cards or the size of the palm of your hand. The cup is about a fist, and the thumb is about a tablespoon. So that really gives them an idea of how they can incorporate in measuring when they're eating outside of a home setting, because we have no control over that. So we can use that. And at the end of this class, after we go and do all of this, we like to ask the patients to commit to one dietary change. You know, they choose it. You know, since some of these patients, they are eating 10 tortillas, and I was like, okay, maybe you can't lower it to the 2 or the 3 that you're supposed to be eating, but maybe it's like, oh, you know, instead of 10, I can try eating 6. And, you know, you give them, you negotiating with the patient is important here, because complete change is not going to be done in 1, 2, 3, 4 months. You know, maybe they can lower it, they come back with 300s and now they're at 200s, but they actually lowered it to 3 or 4 starches. So like, once again, negotiating with our patients to reach that goal eventually of controlled blood sugars. And I'll hand it over to Pam. I don't know if she has questions or.
Yes, I'm going to talk about class number 3, but it looks like I have a question from Jem, who I used to know when she worked in the Valley a long time ago. Hello, Jem. And she is asking, number 1, are the promotores using a standardized questionnaire for the patients to screen them for the classes? Yes, I'm going to let B answer that.
It's not necessarily a questionnaire that they have, but they do, our promotores are trained by us. So the classes that are taught at their homes are based on what they learned they're educated by us, and of course they do go to different trainings. So these have to be certified promotores. They're not only promotores that are just, you know, they come, you know, whoever's giving them the education. They have to be, most of the presentations come from us or from other educators in the community, but they are promotores, not necessarily a guideline or a questionnaire, but they do give us a feedback of how it went to the visit, and we should document that in our EHR.
And when you ask about how was your retention with the classes, pretty good. And we keep track of, you know, whether and sometimes there will be patients who miss 1 class or even 2 classes because of their schedule, and we keep contact with them and remind them when they can come back. But believe it or not, most of them do. If they come to 1 class, they usually finish all 4 because they want that meter. Mm-hmm. And that really is a big incentive for them. And like I said, sometimes we give them the meter before they finish the classes, but then they're coming back because we ask them to bring their blood sugar log.
And can I just add something there? As they're coming, you'll see that some of the patients will be like, I don't want to go to those, and they're just sitting there a little bit grumpy faced. Yes. But once they interact with us, you create, and that's as educators important to have that relationship with the patient. We're the communication from us to the provider, and they begin to have this trust in us, and we end up coming out with, and Pam can tell you firsthand, with a completely different individual from class 1 to class 4. So, you know, it's important to have that communication and that trust from the patient.
Yeah, that's a good point, that they might not want to be there for class number 1, but they end up sometimes being the biggest participants once they get started. Jem, you also asked, are the PHQ-9s conducted? That is usually done in the provider's office. Once in a while, we will do that, but that's part of our standard that annually they are given a PHQ-9. Mm-hmm. I could say more things about that, but when we talk about the mental health issues, that will come up again. So, Jem, I hope I answered your question about the standardized questionnaire, the first question you had about the promotores, but if not, you can write me another note. So I'm going to go on to class number 3. Okay. Class number 3, we talk about medications, and we also have an element we have a dynamic on exercise for our patients. But the medications we talk about, the most common oral medications and the injectables, and we talk about the different classes of medications have different functions. For example, metformin versus sulfonylureas, and we explain why they take 2 or 3 different medications because each medication has a different function. And we talk about the incretins are hormones, just like insulin, and when you have diabetes, sometimes our body doesn't produce enough of that hormone or doesn't produce any at all, or that the hormone is inactive because of diabetes. And most of our patients have a limited literacy level, not all of them, but the majority, and the names of the medications can be intimidating. So I like to do a little exercise, everybody has a pencil and paper in the class, and I like them to just write down the name of their medication if they have their bottle with them, or we can find out what medication they're taking, and just have them practice writing down their medication letter by letter so that they learn to recognize their medications and learn how to monitor and pay attention when they have a visit with their doctor. If the doctor changes the dose or even the medication entirely, that they learn how to recognize those names and check the bag before they leave the pharmacy. And another thing is that many medications have similar letters, but they're completely different medications. For example, metformin and metoprolol, completely different medications. And illustrating that with the patient, writing it out. This is metformin. This is metoprolol. These are not the same medications, but they have similar letters at the beginning. And we talk about insulin because most of our patients are terrified of having, and I shouldn't say most, but a lot of them have a lot of fears about taking insulin. Some of it is related to the needle prick, but there are so many myths out there regarding insulin. And I think different regions of the country have their own myths, but here in the Valley, people think insulin causes blindness, or once you start insulin, you're going to need dialysis because it damages your kidneys. So we ask the patients what they've heard about insulin, and we try to break that down, and I like to remind them that insulin is probably the most natural of the medications that you can take because our body normally produces insulin. Yes, it's made in a laboratory, but it's still very close to the insulin that we produce. And that, for example, insulin is used instead of orals in our pregnant women because insulin is safer. And they seem to understand that. And we explain why insulin cannot be given orally. What's the reason for that? And we need to acknowledge the needle phobia. There are many patients who are terrified of needle pricks, and that it's not that uncommon. And we can usually elicit testimonies from other patients in the class. If there's anybody who's on insulin that doesn't mind admitting that they're taking insulin, and how has it been for them? And they might say, yeah, I really didn't want to start insulin when the doctor told me I needed it, but I've been taking it for so long now, and I could see my sugars coming down. The testimonies from their peers is really has the most influence on the patients. They really relate to that. If I have a patient in my office and I'm teaching them how to use insulin for the first time, I always ask their permission if I can prick them with the needle first in their abdomen, just so they know what it feels like, and they're usually surprised that it doesn't hurt nearly as much as I thought it would. And then they're ready to listen to the other instructions about how to measure it, how to store it, etc. And I have another question here from Alisa. Do you ever have any diabetic patients come to share success stories in the classes? If so, what has been the feedback? Yes, that's a good question. We sometimes ask our patients who we have gotten to know to come back when they've had success. In fact, one of the doctors gave me a name yesterday. I need to call this patient who has lost weight and brought her sugars level down, and he suggested that the patient come to our classes. But yes, patients they really relate, again, to their peers who have had success stories, and they usually have questions for them. So that is a good technique to use. Use that peer testimony. Okay, next slide is our patients' beliefs about their medications. This is one of my favorite topics in the classes that I like to talk to our patients about. There are many powerful myths out there, and patients have many different reasons for being suspicious of their medications, and we need to acknowledge their belief system and ask permission to offer alternative information. To dismiss cultural or unsophisticated beliefs can be insulting, and it doesn't promote trust. So, where do these myths come from? Well, number one, the literature they get when they pick up their medication in the pharmacy, it lists all the side effects. So that can be alarming. There's TV commercials now, and even you'll see it on the commercial. At the end of the commercial, there will be a low voice talking very rapidly saying, if you have kidney disease, talk to your doctor, or if you have liver disease, talk to your doctor. Well, that's alarming to the patient. They pick up on that, and they will admit to you they're not going to take the biggest dose of that the doctor gives them because they're worried about those side effects. So we need to find out where this information is coming from, the misinformation, and we need to demonstrate interest in the patient's concerns rather than dismissing them. The myths can be addressed respectfully. You can initiate a discussion, encouraging the patient to question where the information comes from. Even though they may be limited literacy level, they can still learn to be critical thinkers. So where does this information come from? A lot of times they'll say, well, they said that it damages your liver, or they said that it'll make you go blind. Okay, who are they? And they usually will chuckle when you start talking about that. Well, the people in the street, la gente en la calle, ellos saben todo. Pero ¿dónde estudió? And they'll chuckle. Well, family members, neighbors, they all have something to say about insulin or other medication that you're taking. And these herbs are natural, and my aunt takes this herb and she says her diabetes is well controlled. Well, we talk about that. So how do you know your aunt's diabetes is well controlled? Well, she said she feels fine. Well, have you seen her blood sugar levels? Well, no. Well, does she even check? Well, I don't know if she even checks. So just that kind of discussion gets them thinking about how they need to be more questioning with the information that they get. And it's usually a really good discussion. And we also will get personal testimonies from our patients too regarding the medication they're taking, or again, the insulin. I like to take a phrase right out of the literature that comes with the metformin and the glyburide. And it says, tell your doctor if you have liver or kidney disease. And so I ask the patients in the group, so how do you understand that? And they'll say, well, this medicine can cause damage to your liver or your kidneys. I said, no, that's not what it's saying. And I'm like, it doesn't say that it can cause liver or kidney damage. It's saying let your doctor know if you have that. And if once you develop liver or kidney damage, the liver from a fatty liver or kidney damage is usually from your uncontrolled sugars, uncontrolled in the way you're eating. And I'm sorry, I lost my train of thought for a minute here. So to break down that phrase again and to explain that it's not saying that your medication causes liver or kidney damage, but that if you do have it, sometimes the doctor will take you off of that medication. But you need to remind the patients that they go to the lab before their doctor appointments, and of course their doctor is analyzing all of their lab work, which tells them how their organs and their body systems are functioning. and they seem to be attentive to that. And for the sake of discussion, I might ask patients, well, what about some of the foods that you eat? Do any of them have side effects? Well, yeah, manteca. Okay, what can manteca do? Well, it can clog your arteries. That's right. But, you know, there's no warning on the tub of manteca about the damage it can cause if you overeat it for a long period of time, right? What about rice? If you overeat rice and tortillas over a long period of time, is that a contributor to developing diabetes? Well, yeah, but, you know, the bag of rice doesn't require that. Doesn't say that on the bag, does it? It just gives them an opportunity to see another perspective and, again, to be questioning what kind of information they believe. And, we talk a little bit about home remedies and herbs and home remedies. And usually in my presentation, I will list some of the ones that I've heard about, like moringa, neem, and what they've heard about these herbs. And again, to be questioning about the information that they're getting, where does it come from, that the medications that they take from the doctor have had years of research done on them before they're able to sell them on the market, and your herbs and natural remedies usually don't get that much research, so we don't always know what they do or how they do it, or if there are side effects, or if they're okay unless you take it with another herb or with the medication you're taking. There isn't as much information out there. And again, I just advise patients to talk to their doctor about what they want to take, and of course we know they don't probably, but they might tell us what they're taking, and be willing to do a little research on these herbs and share with them what you've discovered. So I think we're ready to go to the next page, which class number 3, the last part of the class, is the physical activity, and I'm going to turn this over to B again.
Yes, class, the second part of class number 3, we like to go over some of the precautions of how the blood sugar and exercise. So one of the things we advise them is to check their blood sugar, and how Pam mentioned at the beginning that the meter is a tool. So this is their tool to read their body, so they can see the difference of how exercise impacts their blood sugar levels. And going back a little bit on the precaution is that once these patients are actually making changes, you'll see that they might go hypoglycemic. As they're coming in with us, with the educators, we have one-on-one, and they might see them running low. So we tell them to check their blood sugars before and after they exercise. One, to see the difference of once again, how I said, how it impacts their blood glucose levels, but also to become aware, and they can read their own body, what is the hypoglycemic symptoms that they might have. One of the suggestions I like to give, and I always tell them, and they laugh, only for emergencies, especially if you're going out to the park or somewhere out of your neighborhood, to take a little cooler and have a regular soda and a juice, and of course take your meter with you in case you're feeling hypoglycemic, to check it. And how Pam mentioned before, they might be at a 140 and they're feeling hypoglycemic, doesn't mean that they are hypo. So, educating them on that, and to carry that just as an emergency, or even a regular candy. I also do a group participation of low impact exercise. Some of these patients, you'll see, I'm already walking, I'm already doing water aerobics, or things like that.
Zumba.
Yeah, Zumba, that's one very popular here. But one of the activities that I like to do is exercise sitting down in a chair. Basic exercises they can do while they're watching the novelas or even the movie. I tell them it's better if you do the exercises with the commercials, because those commercials last like 15 minutes. So I tell them to do, you don't necessarily have to buy any specific exercise material, but, you can use water bottles or canned goods to use them as little weights so they can pick up their arms. They kind of simulate jumping jacks with their arms, moving their legs, walking in place as they're sitting down. So these are things that patients can do, especially if they're morbid obese. You see this obesity, this patient's like, my legs hurt, I cannot walk, or they have, arthritis, there might be different pain, different kind of other complications, not complications, but other different things that they might be suffering. So these are things that I like to go over with them. I also like to recommend to break down their exercise routine. If they have never exercised in their life and they go exercise for an hour, they will be sore and they were probably not going to do it again. So one thing is that try 30 minutes in the morning, try 30 minutes in the afternoon, so they can be able to complete the goal of an hour daily. Or maybe start with 15 minutes for the first 2 weeks, then slowly start adding 5 to 10 increments of minutes, eventually into reaching the goal of an hour daily. I always tell them to advise someone where they will be in case of an emergency. It's important to, some of these patients don't want to tell a family member or their neighbor, I have diabetes. If we go back a little bit on the acceptance, these patients do not want to say that. So I tell them at least advise someone or carry a proper identification with them. And the following slide that you guys see in front of you, it's a diabetes registration card. You can fold it up and it fits in your wallet. And I underlined it on the image on the left. I got it at the TexasDiabetesCouncil.org at no cost to order to your facility. And it's a patient's responsibility to and it lets them know that they're carrying diabetes in case they go unconscious. The first thing that the paramedic's going to go and look in there, try to identify them. And it also serves as a guidelines for them to ask questions with their MD. You see on the right side, you also see that it has the A1C, triglycerides, and for them to keep their own personal record of that. And if we go over, that's the last part of number 3, but in class number 4, we talk about all the complications of uncontrolled diabetes, and that's one phrase that I emphasize, uncontrolled diabetes, because by the time I finish class number 4, my patients are with their eyes wide open, scared. I was like, I have to go through all of that, and I go again, uncontrolled diabetes. We do discuss all of the complications, eye, cardiovascular, oral, etc., all the ones that you see there. But one of the things that have shown success with us is the visuals. We use test tubes, and out of ketchup and vinegar, we created blood consistencies. We show how their blood sugar is at 120 versus 300 or, 250. During the class, we check their blood sugars, and we've had patients before, I was at a 250, and that's how my blood sugar looks. So they can kind of have an idea, I don't want my blood sugar to look that way, or, we're putting a lot of more strain into the heart or things like that. Also for the kidney, the way I like to explain the way the kidneys work is using a coffee filter. We put the coffee grains there, and I ask the patients, what do we like? Do you want to drink the coffee grains? No. I say, well, that's how our kidneys work. They function. They're like a filter, and we only going to use what's a good use to us. And one of my favorite ones is the electrical cord for the neuropathy. I have an old extension cord, and we kind of cut it, and some of the wires are sticking out. And I tell them, what happens if I connect this cord to the electricity? Well, you're probably going to see some sparks, or, I probably get a little bit shocked. So I tell the patients, most of my patients that have neuropathy feel that they have shocks going up and down their legs and things like that. Or what happens if I completely cut off that cord? There's going to be no communication from one end to the other. So that's why we see a lot of the complications in the feet, and they're like, it makes sense, or you probably don't feel the same severity in a particular wound or things like that. And from there, we also talk a little bit about the sexual complications. The doctors, even us, we go to a physical, doctor's not going to spend 10 minutes with us. They should spend at the most 5 to 7 minutes with us, even in their physical, us that were somewhat healthy. And then we like to tell them, when men can have an erection, women usually experience dryness, fungal infections. The sensation is no longer there. The desire is no longer there. And a lot of the patients say, I feel fine. But when they hear that, some of these are the complications, they're like, maybe I should control my blood sugar. And of course, educating them that most of these will go away if they have controlled their blood sugars. Will improve, I'm sorry. We also like to, going on to the mental health and diabetes, we like to help our patients identify the symptoms. How Pam mentioned earlier, some people have diabetes for 20 years and they're still upset, they're still angry, they're still in denial and sadness. So, it comes, and I like to ask the patients, how did you feel when you were first told that you had diabetes? And they're still upset about it. So you see a lot, and the difference between stress and anxiety, It might be economic issues that they might be going through, family problems, food insecurity. How I said, we don't know what they're going through. As also our migrant workers go out to the field, they leave their family behind. They might have different stressors. We see some patients leave and they're controlled and come back, and they're coming back with the different stressors. So we see their blood sugars going up, and the connection between these two, we like to educate our patients that that's one of the causes that if they have depression, anxiety, or stress, suffering from one of those, that their blood sugars will elevate if this is present. Because patients can be doing everything on the book to control their diabetes. They might be following the meal plan, exercising, taking the medications directed, but it's still uncontrolled. I don't know if you want to ask something.
Yeah, I don't think we spend nearly enough time on the emotional effects of having diabetes and the connection between depression and stress, anxiety, and blood sugar levels. And the patients are often surprised themselves when you ask them about stress, and they are surprised that can affect their blood sugar levels. They're so focused on what they're eating and maybe their medications, and they need to be able to discuss that with somebody. And I think it's been on the slide, if we haven't mentioned it, but we do have a behavioral health department here in the clinic, and sometimes we can make referrals to that department. A lot of times patients are afraid of having to take one more pill because they have depression or something. And it's just, it's a time for the patient to talk and us to listen about what's going on in their life. And if they don't want to take medication, nobody can force them. If they don't want to talk to anyone else, no one can force them. But sometimes they do come to the point where they realize that they need some kind of help with these issues. And I think that is basically everything in our presentation. I can open it to questions now. Somebody asked if we can send this presentation. Yes. If you want a copy of it, you can. I think Sylvia can send it to you.
Okay. Well, thank you both very much for that great information about your health center. We hope that it has been a helpful example of a model program for you all that will be useful in a similar program at your health center or in developing one. I'm looking through the chat for any questions. If you have any questions, feel free to send an email to either of the presenters or to myself, and I can forward that question to them if needed. And thank you very much for joining us this afternoon. We can still take questions if you have any, so we'll be on the line for a few more minutes for any questions.